Thank you to all of those who are able to join today. Very excited about the panel discussion on artificial intelligence and the impact on research and health. We have two great panelists who are going to really share a lot of great information. It'll be a great learning experience for me in particular, and I'm sure many of you. Let me introduce the panelists very quickly, and then I will turn it over to Jareen to begin. So first, Dr. Jareen Meinzen-Derr serves as the co-director for CCTST at CCHMC and UC. She is co-director for Faculty Diversity, Equity, and Inclusion at CCHMC and a professor of biostatistics and epidemiology at CCHMC, where her research focuses on understanding and optimizing developmental outcomes of children who are deaf, hard of hearing, so that all children can reach their full potential. Dr. Meinzen-Derr actively collaborates, teaches, and mentors faculty and students across the Academic Health Center, focusing on facilitating research, promoting equity, and community health. And Dr. Eneida Mendonca is the director of the Division of Biomedical Informatics and Regional Chair of Biomedical Informatics. She co-authored the National Academy of Medicine report on artificial intelligence in healthcare, the HOPE, the HYPE, the PROMISE, the PEARL, with an emphasis on particular chapters on the potential trade-offs and unintended consequences of AI and deploying AI in clinical settings. Dr. Mendonca has developed innovative clinical information systems that are used at New York Presbyterian Hospital, Columbia University Medical Center, and Cornell Medical Center. She pioneered the use of natural language processing in biomedical literature and in the narratives within the electronic medical record to support medical decision-making and enhance patient care. Many thanks to the panelists, and I will turn it over to Jareen.
Thank you so much, Josette, for that very nice introduction. I am going to share my screen and give everybody 1 second while I do this in a way that I bring everybody back to the screen that I'm looking at. Very good. And I want to make sure that the right screen is being shared. Does everybody see my?
Yes.
Correct. Okay, thank you. We also definitely want to have a floor for questions and discussion. And as I'm going through and you have questions, please place them in the chat. And what we'll do is we will get to those questions as soon as Dr. Mendonca's talk is finished. That way we can have a little engaging conversation at that time. And I am going to go ahead and get started. My focus of the talk is really going to be around the data itself, not AI or algorithms per se, although you're going to learn that they're very, very much entwined together. So broadly defined, electronic health records represent longitudinal data. It's an electronic format, and they're collected during routine delivery of healthcare. And according to the Institute of Medicine, electronic health records should have, it's defined as information pertaining to the health of an individual or healthcare provided to an individual. They're supposed to have provide immediate electronic access to person and population level information by authorized and only authorized users. It is a provision of knowledge and decision support that enhance the quality, safety, efficacy of patient care. And it supports efficient processes for healthcare delivery. And I think what's important in terms of what is it that an electronic health record is and what is it supposed to do, what's important to understand is research is not part of the definition of an electronic health record. There are lots of great opportunities, so I definitely don't want to ever discourage us from really understanding all the great opportunities that there are to harness the information that's within that health record, anywhere from quality improvement and public health initiatives, replicating results of clinical trials, thinking about practicing precision medicine, linking it to contextual data that's outside of the electronic record itself. And I think that the opportunities were so vast that it was estimated that institutions were going to be investing upwards upwards of $6 billion in artificial intelligence for healthcare, specifically in 2021. So this is not an inconsequential amount, and it makes our need to truly understand the data that go into this vital. Which means we really have to think critically about the data. And that is when we're talking about any algorithms or using it for any purpose outside of what that data were meant to be used for initially. And it's helpful to think about healthcare and humans as part of a complex, nonlinear, chaotic system that has inconsistent predictive relationships. Algorithms can only repeat our past, so they don't have a moral innovation to try and improve our lives or our society. And I think this is also very, very important for us to keep in mind, because AI algorithms need to be developed, trained, and tested on data that represent clinical scenarios encountered in real-world settings. And this is with patient populations that are representative of all those patients that we need them to be representative of. I find this framework a little helpful to think through when we're talking about our using clinical data for research purposes. So we see on the left how research is very defined, it's very structured. We talk about, we have pre-specified follow-up visits, we have assignments for treatments, we monitor exposures, medications very closely. And then when we look on the clinical side, what we see is everything is variable. Everything is highly variable. And treatment decisions are made on clinical impressions and needs. Exposures are monitored just depending on need. The intervals of follow-up vary accordingly. And so we have to think about all of these factors when we're thinking about the use of electronic health record data for research purposes. And keep in mind that all of what we're talking about today can be ideal in an ideal world. And things like artificial intelligence, machine learning, any predictive modeling scenario really require high quality data sources on which to learn and classify data in relation to those outcomes. And when high quality data is there when they're accurate and when no measurement error occurs, when people behave the same way, and when data are not biased. And the truth is, we don't live in an ideal world. Biases in our data collection can be substantial. Models that are learned from the data that carry the biases of the data and then can potentially amplify them. And so this is important for all biases. So algorithms replicate the social biases that exist in the systems they are supporting. And I think that's always important to really keep in mind. Populations that are over or underrepresented in our data will experience continued marginalization and failure of those algorithms. These are all really, really important components to keep in mind because our world is not ideal. There are issues also for using healthcare data for research. Healthcare data is not structured in any way to facilitate research. That was never its purpose. Providers decide where to put information. Information can be entered in free text. It does not have to be structured or finite. Providers use different terms for the same information. The information is not always stored in the same way that is readily searchable. And data that's not important in clinical care may actually not be in the record, even though you may realize you need that later on. So simply starting with acknowledging that healthcare data are not structured to facilitate research is the first step in truly understanding how to use data, healthcare data for research purposes. We also need to be cognizant of the fact that the data cannot easily be integrated across people, time, or place. The information is collected for billing purposes, and that does not fully reflect underlying diagnoses or treatments. Data collection practices that are highly biased towards those who can already afford or who can readily afford healthcare services exist. And data quality issues do happen within the healthcare, within the electronic health record. We're going to talk a little bit about those data quality issues. We're also going to talk a little bit about the biases that happen before anybody even enters the healthcare system so that we're all acutely aware. And my part of the talk is really about us getting that understanding of the biases in the data and maybe some thoughts about who we need to be including on our teams and how we need to be going from there. And I'm going to let Dr. Mendonca tell us the rest. We also have to be very cognizant of who's contributing data into the electronic health record. So if we're in a hospital setting, we have to realize that we're often talking about individuals with illnesses or who are hospitalized. We have to think about not just where they're receiving their care within the hospital setting, and also why they're receiving their care within that setting. We also know that hospital-based data are not representative of all individuals. Many individuals don't walk into a hospital, and so you're only capturing those who need a hospital setting. And not all hospitals are the same. So if you're even thinking just about the Cincinnati, area, the population that it tends to be seen at Bethesda North is very different than the population that tends to be seen at the Christ Hospital, which is very different than the population that tends to be seen at University of Cincinnati's hospital. So not all patients are the same across all those hospital settings. And we also have to be aware that inequities that exist prior to entry into the record will in fact also exist after entry into the record. So I've given this sort of similar aspects of this talk before, and I like to think about how the data sort of flow from beginning to end when we're thinking about data quality itself. And we know we're talking about from the encounter to when we're pulling the data out for whatever research purposes we have. And in that process, we know that errors can occur at multiple time points throughout this process. We also, even though I'm focusing on the electronic health record, so this point of interaction here, we also know that a lot of the biases that we talk about actually have been occurring well before a patient might walk into the door. So let's talk just quickly about, well, what do the data look like that are housed within that electronic health record? We have both structured and unstructured data. So we're talking discharge summaries, treatment plans, progress notes. All of this will include data that we might want. It can be anywhere in the record, which is a level of complexity that we have to also take into account. And so we're talking about charting, and it might be in the physical assessment, it might be in a nursing note or care plan, it might be in histories and diaries we ask patients to fill out. And it might be in immunization registries and treatment protocols. So all of these are the areas we have to consider when we're pulling data out. And it's recorded by a variety of healthcare professionals. And in fact, we can go anywhere from coded dictations that occur with administrative staff and data recorded by patients themselves directly into the record. So all of these components actually play a role in the quality of the data that we are interested in reviewing or using for our research. And most importantly, all of these data are dynamic. They change frequently and it's fluid. And so the record of somebody today is not going to be the same record necessarily of someone next month or even next week. And so those are pieces we have to consider. And remember when I said that data just doesn't start when someone walks in the door. In fact, historical data captures patterns of healthcare disparities. And so here we're just looking at a very, very simplified sort of visual of what we might be talking about. And so we have to actually back out of the door of the system all the way and thinking about the lifetime of systemic and interpersonal bias that someone may experience. And so, for example, classism and racism, this will play a role into that data that we are wanting to use for our algorithms and our modeling. We also have to think of the structural bias that was in place. So where is the hospital located? Is it easy to access? Does it take the health insurance of the population in which we want to study? And then your interpersonal bias within that healthcare system itself is also going to play it's going to shape that data that we want to analyze and use. So the relationship with the clinicians may in fact create a biased way of biased data collection and way of bias, introducing bias in the answers that we're receiving, the way patients might be treated, the trustworthiness they may feel with an institution, and their lived experience. All of this plays a phenomenal and important role in the data that we're collecting, and not just in the bias and just how we collect that data. So there are many, many layers that we have to think about before we're even getting ready to sort of dig into the data itself. So there are examples of how these long-lasting disparities and long-lasting structural and systemic biases, racism may in fact play in our current system. So this is an example of a commercial risk assessment algorithm that was actually developed to help guide clinician decision-making around discharging patients and how to in fact provide the right resources for patients who are discharged. This was deployed on over 200 million patients. And when they went back and reviewed how the algorithm had been working over time, they realized that patients who were white, who were assigned a specific risk score, were in fact healthier than the patients who were Black, who received that exact same score. And what they realized was that the system itself was developed and trained based on future healthcare costs. So the patients who were Black were receiving less expensive care, and they were receiving it due to existing systematic biases that were at play. And what this showed was that there was a bias in the algorithm used because of the bias that was in the data, and that the algorithm itself was predicting healthcare costs rather than illness. And this was a reflection of the unequal access to care that was occurring among Black patients. And so they were in fact spending less money because they were receiving less adequate care. And by deploying the algorithm, they in fact perpetuated that bias, as opposed to using the algorithm in a way to support individuals who needed more means, more support, more healthcare. We also have to consider the dimensions of data quality. So here we have completeness. We have to think about the correctness of the data, whether or not there's agreement between elements of the data within the electronic record, whether or not it's plausible. So when you see a data element, does that make sense? And whether or not that element actually is a relevant representation of the patient at that state given point in time. And they're really reduced down to these three fundamental and non-reducible core concepts. And I actually think completeness and correctness is probably where we spend most of our time when we're thinking about data quality in the record. So let's go through a little bit about those data quality considerations. So we know that there's variable data quality due to differences in measurement and recording, information systems, the clinical focus. We know that there are data entries that data entry errors that definitely can occur. So medication discrepancies are often very common. We can see adjacency errors. So the electronic health record these days have a pull down menu and you can choose A, B, C, or D. And sometimes if you're not used to the menu, you may, or you're working really quickly, you may choose C instead of D. There's also copying and carrying forward within the record. So which, if not edited, can in fact introduce errors. Then there's a series of errors that can occur within the coding and the standardization practices or the actual extraction of the data itself. And then data in the record is very context dependent. So data that I may pull from one area may be of better quality than data I pull from another area. So if I'm thinking about somebody who may in fact have, let's just say autism spectrum disorder, if I find that element only in the cardiology record or note, I might think that is not as high quality or as valid as or reliable as finding that in psychiatry or in developmental pediatric notes. So where that data are housed is in the context behind why it was collected is very important. And this also goes to understanding workflow and documentation habits. This means that understanding how busy those clinics are, how easy it is to add information into the record, where errors may occur within that workflow, those are all impact that quality that we're seeking in our electronic health records. There are challenges with the data completeness, so fragmentation of healthcare systems. We know that people travel from one healthcare system to the next, and therefore, if we're only focused on one healthcare system, we're going to miss a lot of information. There may be poor and inaccurate documentation on both parts of patients and healthcare providers. We know that sick patients often have more data. And missing data from a record is not always an error. At least clinically, it's not considered an error because sometimes the data are missing because they're irrelevant to the patient. I'm not going to ask my 5-year-old patient or my 10-year-old patient necessarily if they're smoking. I would ask an adult. And if I'm interested in smoking, I can't assume that a missing means that that was an error in the record for all pediatric populations. So there have been research in this, just so that it shows that I didn't make up these, even though they seem to be sort of self-evident. So there was a study done across hospitals in Massachusetts and all emergency departments within Indiana, and they noticed that up to 40% of patients had clinical visits across multiple institutions. In fact, 50% of all those visits occurred across multiple institutions. A study that looked at EHR sources of data found that 55% of the research studies, clinical research studies that used that EHR data actually had to supplement that data with patient-reported data, sometimes actually calling up patients and asking them additional information. And there was a study that looked at ICD-9 codes of pancreatic cancer and found that nearly half of those who had an ICD-9 code for pancreatic cancer actually didn't have the corresponding pathology documentation. It was either incomplete or incorrect, which meant that more information investigation needed to occur before research could happen using that particular field. We also know that sicker patients have more data. So in a study that was done on 10,000 patients who received anesthetic services at one academic center, what they noticed was that patients who had a more severity illness classification, as shown here on the x-axis, actually had more data available for research. So they had more meds and they had more lab data. They also had more complete data. So patients who tend to be sicker tend to have more completeness of their data. And then, of course, we have basic inaccuracies. So this means that massive data cleaning always needs to occur. This was a study of hospital episode statistics, and we have 3 graphs here. And if you look at the top chart, what you'll see is that within a child, adolescent, and psychiatry visits, that they found that more than 16,000 visits within 1 year were of adults from 30 to 90 years of age. And here in through geriatrics, or geriatric medicine outpatient visits, they also found that more than 3,000 of those visits were from children. And then the most interesting one they found more than 20,000 males that were admitted to an OBGYN inpatient admissions, including males who had actual midwife episodes. And then finally, we do have biases in our cohort definitions themselves. So here we have Fine et al. Used data from a pneumonia patient outcomes research cohort study, where he defined pneumonia severity, defined a classification of a pneumonia severity index that you see there on the x-axis, and where 1 is the healthiest and 5 is the sickest. And what you'll see is that for the healthiest classification of those with community-acquired pneumonia, they had the lowest mortality rate. And in fact, it did a great job at predicting risk of mortality among those with the more severe classifications. HIPSRAC came along years later, 10 years later, and adopted this exact same algorithm for their New York Presbyterian Hospital clinical data warehouse. And they wanted to do the same thing and use it for the same reason. And this was really to decide patients whether they needed to be discharged home or whether they needed to be admitted. And so it was supposed to be a great tool. Well, when they applied it to the second hospital, what they found is that not only were mortality rates higher, they were higher in the lowest classification arm right here, which was very concerning. And so they had to actually do a deep dive and go through the charts and figure out why the algorithm was not working. And what they found was that the definition of the inclusion was vastly different than the algorithm was originally designed for. So they included those who arrived and died in the emergency department. They included individuals who did not have pneumonia, regardless of what was identified within the record. And they also significantly misclassified the severity of the illness. And so they had to go back through the records and reevaluate their inclusion criteria. And when they did, they realized that they could, in fact, mimic the original study. But this just shows you that an algorithm that is actually created on one population may not, in fact, be that easily transferable to other populations. And finally, quickly, we're going to go through the fact that unstructured data within the electronic health record has lots of great information that we don't want to miss out on. And these are the data that are in the notes. And the important thing to know is these are data that really do require specific knowledge around the techniques that need to be used to extract this information. There are grammatical errors and spelling errors that make this definitely a challenging job. It is extremely time consuming and it requires a lot of work and validation. And the notes actually are subjective. So they also house discrimination and stigma that we have to be extra vigilant about. And there's other quality issues, of course, consistency and completeness, because it is a free text. You can write anything in there. Okay, whirlwind on data. So we have to keep in mind that the data set descriptions for specific applications do not address often do not address potential sources of biases. So we have to actually bring that to the table and think about them. The patients not identified by algorithms, misclassification, observation error, and misapplication need to be considered. And that the historical data that we're using captures patterns on healthcare disparities, models that are developed on these data, often to perpetuate those disparities. We need to think about including our diverse team members. So think about the individuals who understand health inequities and health disparities and put them on your team. We obviously need to continue using sophisticated methods and coding algorithms and reevaluating these specifically around addressing bias and confounded data. And we need to improve how we capture social and behavioral data so that we can supplement what is in the record and we can better understand the health inequities we want to identify. This may also include linking to those contextual data sources like vital records, environmental data, etc. And I think in the end, this is just really us being constantly aware of the bias that may in fact exist or actually does in fact exist in the data and from all types and all angles. So I'm going to leave you with this, that there are a lot of small data problems that occur in big data and they don't disappear because you've got lots of the stuff. They get worse. And I am going to stop sharing and turn it over to Dr. Mendonca.
Okay, thank you, Jareen. So let me just move here. Share this. So thank you for the excellent introduction, Jareen. You talked about everything that I can talk now. So we are done. Now I'm actually, well, thank you first for the invitation to speak. It's great to be here to talk about a topic that I love a lot, which is, AI in the clinical and research settings. I think, as we all know, AI has been a big hype. There's several drivers for using AI in healthcare. It's exponentially increasing in everything we do, but I think one of the most important things is that the conceptual things are there for AI, and Jareen covered a lot of this space on how we can be biased or not biased, how we can look into that so that we are able to create systems that can actually be translated from the theoretical model to an usable technology that we can apply at care and research. So I'm going to take a little different spin, and Jareen talked a lot about the data part, the components of the data, the bias on the data. I'm going to move us to more like, okay, we have all that, we understand, we try to understand that, but what are the other consequences or unintended consequences that can happen if we don't pay attention to some of those things, right? How do we actually go one step further and we try to have an effective use of AI? You know, AI, the effective use in AI right now gives us an opportunity for thoughtful engagement. Jareen talked a lot about disparities, right? And this is an important component. Talked about including folks that are at the point of care, that do understand the types of data that we are using. You know, there is a lot of examples in AI that has been used before, but really deployment of what we actually plan from the research to the clinical side is not as much, right? And when it is, we need to pay attention to several things that included the bias that Jareen mentioned, but also the populations we are applying this to, the populations that the algorithms were based on, and so on and so forth. So we really need to adhere with best practice and workflow placement of AI and decision support to incorporate this into real clinical practice and to actually impact care. So I'm going to talk about some of that dynamics, right? And as we learn more and more with the new, the way we try to imagine this is really like a dynamic system, right? Some of you may have learned about learning health systems, right? Where we learn from the data, which is what Jareen was showing. We create the algorithms, we apply in one institution, we learn from that institution, we apply to another, we validate, and then we apply to care. And we learn from what we are applying, and then we redo the processes again and again, right? That's sort of like we learn from our own data and we try to improve how we apply care. And this is sort of like an application. When, how, you know, where, there's several uses of AI in healthcare. I don't need to tell you about that, but more and more we can use AI for, you know, care delivery, patient care, care replacing applications like mobile devices and other things that can track you and help you with advice, non-standard care systems like schools, risk prediction, all of these things. And there has to be some organizational approach to this implementation of AI that takes in consideration a lot of different aspects. And I'm not going to talk about all of this today. I'm just putting this here so that you can have a sense of how complex this could be. It's not only the bias of the data, but there is all these other things in the environment, including ethics and fairness and safety and efficacy regulations and others. This shows a little bit about the life cycle of AI applications and how, which is what we discussed before, right? If we try to learn from the wrong data, from data that's not complete or biased, we are going to learn something wrong. We are going to apply something wrong. We're going to have bad results, and then we're going to continue to move on that. But if we pay attention to some of that, we can actually have good workflows in place, identify the needs, describe the workflows, identify the target, create this developing system, and then implement in the right way. And most important, we need to monitor what we implement. So how could then, if we know what can do, how can we improper use of AI hurt our patients and hurt the healthcare system and us, right? So those are the things that we need to pay attention. I'm not going to spend a lot of time as this, but Jareen already mentioned the poor constructed interpreted models from observational data, right? You learn from what the data you have. If it's not complete, you're not going to learn it right. There are some constraints on what we learn from that data, especially if it's the HR data, right? We can learn the HR can be not so complete, not so correct, and we actually need to validate everything we learn. So we are limited within the underlying data that we have, noise bias. We really need to pay attention to that. And certainly, prediction models can fail to generalize from tenure to implementation, and Jareen showed a couple of examples from that. So interpretability is something very important there. How do we interpret those models, and for what purpose we are using some of those AI models? which quite important. The other two things that I want to mention here is one is, what are the difference, in correlation and causation? Not everything that in the algorithm show that they are correlated means that they are causation, right? The one causes the other. And there is a lot of misconcept on that we need to pay attention when we try to use that data to try to understand a process or a problem or a disease, and then be able to do it. The same with prediction and action. Not everything that we can predict, we can act upon it. So I think there's a lot of issues there as well that we need to pay attention as we go from there. And interpretability of the different models is different depending on the model as well. There are neural networks that are considered black box models, for example, that are very hard to interpret. But they're very good for certain types of prediction, like using signaling systems in signaling. The other important thing is amplification or exacerbation. We learn from the data, so we need to understand what that data is trying to tell us, right? One interesting example that I find on this is the Amazon hiring algorithm. Now, at one point, Amazon had an algorithm that was hiring, and they used implemented their data to generate an algorithm that will help them to hire more. What happened in there is that in their algorithm, there was more men being hired than women at any point in the past. So they learned from that. So what happened? They continued to hire more men. Actually, they doubled the number of men hired, and the women were behind again. So they were learning from a different model, right? So that they were getting that wrong. The same constant vigilance on that, I think it's important. Jareen mentioned another algorithm that I always mention, which is the pneumonia, the Columbia University example of the pneumonia. And they did based on their algorithm, but they didn't realize they changed care in the middle of the algorithm. And then that change in care actually ended up that patients who actually needed more care were actually not putting better care. They were actually removed from there. So that also could not be applied. So you really need to pay attention to that observational data that you have to be able to create algorithms that will be able to give you something that you can use on. And constant vigilance, algorithm surveillance, sort of like pharmacosurveillance, right? Really trying to look into the algorithms, check on the data, and maintaining that algorithm, because data also changed. The data changed. As you know, CD90 was a CD10. If we do an algorithm based on that, it's going to change. There is new genes, new proteins. There's new things that happen all the time, new medications, and that needs to be a constant in there. One of the very interesting studies that I've seen that shows a lot of the inequalities, and Jareen talked a lot about bias and inequalities of algorithms, was this study back in 2019 that brought a lot of discussions. So this was done in a large academic hospital. What they were trying to do is to create algorithms that will score patients based on the need for care, right? So remember, Jareen showed a slide to all of us saying that patients who are sicker get more care, right? And patients who are less sick get less care, right? That's one of the things that happened. But in this case, they took a hospital that had, an academic hospital that was providing more care. They look into the amount of care patients would receive. But the patients who were receiving more care were not the patients that needed more care at that point, because the patients that needed more care were not getting there. They were not even getting at the hospital. So, and what they were trying to do is to really target the population that need more care to provide additional care, right? To provide better care, additional care. And what they end up doing was that they end up getting more care to the people that already had care, right? And the ones that did not care continue not to have care. So they did the algorithm with one reason, for one purpose. They tried to use for a different purpose, and that didn't work very well. So really trying to look into what they end up estimating that it even reduced the number of African-American Black patients who were actually receiving extra care for more than half. So this is like huge. It's like humongous, right? So there was a lot of things that using cost and health costs for proxy for health needs is actually not perhaps a good idea unless you are trying, you better understand how you use that. So those are little things that we need to pay attention, but they can bring a lot of bias into the algorithms and to what we are trying to apply. And this was actually applied in that institution. So just to recall attention for that inequality and the bias of your data in how you apply. Another interesting concept that we need to pay attention when we are looking to algorithms is transparency of your algorithm, right? Try to protect the consumer privacy as well. We do a lot of work in NLP, and transparency is really one of the underlying deeper issues. I think that when we look at the data for patients and we try to work with in research, especially with patients' data, EHR data, is the progressive integration of the data and the re-identification of the data. Why I'm saying that? As Jareen mentioned, when we look at EHR data, we look at patients who have more care, but we are using their data without sometimes their consent, or we are using just the retrospective data, which is important to do. But I think as we learn more about AI, as we do more AI, perhaps one way is educating the patients, because a lot of that information is not in the HR records, it's actually at the patient level, it's patient-centered, patient-generated, and we do not have that, right? So perhaps the way of making this data more, let's say, between quotes, complete, accurate, is really try to engage the population and bringing them on board and be transparent with them about the use of the data, about the risk of the use, and so that we can have better data corrected with data generated by patients as well, and be able to reproduce and validate as we expected. So that's just a side comment here on the bias, because I think when we don't engage as much the patients in providing us the data as well, we are only at the EHR data level, which may not be appropriate and adequate for what we are trying to build sometimes in terms of risk prediction, for instance. This goes a lot with, social determinants of health and the things that are stuck on the clinical notes and things. This is one more issue when we talk about bias and noise in data. We sometimes forget imaging data, right? And I just wanted to call a little bit of attention to the imaging side. And this is an example of a breach in private medical imaging. But the idea here is to show that, if we have an image and we have some diversion noise, we may actually change the prediction for not being predicted for diabetic retinopathy to being totally predicted for diabetic retinopathy, just because the image has some changes, right? Some little changes that are not really perceived by us. So trying to really bring that concept of, it's all in not only EHR coded data, it's not only that narrative that Jareen mentioned, all the difficulties, but I wanted to bring the imaging component as well, because it's important as we see the patient as a whole, right? Jareen mentioned population kinds of data, right? Social determinants, death data. I'm bringing now imaging. I try to, bring the person as one unit, right? With all the different aspects of that. And the other thing that I think it's important in all of this is really the education of the workforce and workforce development in this area. Really professionals that learn how to use the data. Jareen talked a lot about types of data, different data. Do we know all these data? Do we understand of this data? Data literacy, understanding of algorithms, understanding of how do we apply those things in the point of care or in research is important. Not only for the people who are developing this, but the ones that are using this, right? Clinicians in general. Right, so I think that's just important to me, is to address that component as well as the bias component, because more and more people are educated on how to use data for care, more we are going to use data in a correct way for care. So I think that's my spin point here, in a completely different point, not talking about data, but talking about training. And for those who know me, I like training. I'm passionate for that. I just wanted to get us 10 minutes for our conversation. So I'm going to close just with some key considerations here. AI is good. AI is launched before, got down, is up again, may get down again. And I think in part, this is because we need to try to better understand how to use this in the correct way. In the correct way. We can be harmful if we miss the opportunity not to use, right? But we can also be harmful if we don't use that correct, right? And we saw several examples of that here, right? If we start creating algorithms that create even more discrepancy, create more, that we don't look into the inequalities that they are creating, we are going to go wrong and we are going to go down again. So I think that's something very important to do. We need to do our best to avoid that unintentional harm, as we all know, right? Respect decisions of folks want to participate when they are trying to bring us data, and participating in research studies is quite important. And I think that's another key component of that. And really bringing justice, acting on the basis of fair adjudication between compelling claims, reducing disparities in access is extremely important. And I think that's my major point in here in order to do that. This is part of our medical ethics framework, and I think that's quite important to always remember how to do this. And the only last thing I'm going to point is for the National Academy of Medicine AI Intelligence in Healthcare report, which is free of access. And for those who are interested in a very broad view of AI in healthcare, I think that's a very good little reading for that. And if it's too long, there's an executive summary that people can read and take a look at that, or some of the key aspects of this. And I'm going to stop sharing so we can have some conversation.
Great, thank you both so much. The chat is open, and in the interest of time, if there are folks on the call who would just be willing to join in and ask your question verbally, feel free to do that as well. I don't see any questions so far, but I do have one to start with, if it's okay. Both of you talked a lot about the institutional impact, right? So there's systemic bias, there's institutional racism that impacts the development of algorithms, or they weave their way into that. I'm curious, and you listed several tangible examples that have real life impacts on folks. I'm just curious about how you are looking at ways that algorithms can be developed to incorporate or counteract that institutional bias or racism.
No, I think that's a great question. So I think there's a couple layers to that. One is the algorithm itself. If the algorithm produces biased results, it's simply because the data that went into the algorithm are biased or are incorrect. And our ability to interpret the data coming out of it, we're interpreting it with a biased lens as well. If we want to make those data better, we actually have to think about how we are addressing things like systemic racism, systemic bias at the institutional level. And I think that, that's what you have to do. And so we can't just magically make the algorithm better just because the data is not better. And so we can't do that. So I will have to say it has to be a large systemic change that needs to occur for that to be better. I'll also say, and Eneida might can chime in on this too, that we have to constantly evaluate and reevaluate the algorithms that we put out there, because they can change over time. We need people to look at them and let us know whether they're biased, let us know where our own blinders are and pitfalls. And I don't know, Eneida, I'm going to turn it over to you so that you can talk about the modeling piece.
Yeah, so there is a lot of, I agree with everything Jareen mentioned. I think interpretability is a key issue there. Really understanding what you are creating that algorithms and you're applying it to, right? What you're trying to answer with that algorithm, right? Sometimes some of those examples that we looked at, they were created for one purpose, they were used for a different purpose, and that really brings some of that bias and inequality and confusion, and it's not good. So systematic bias, of course, if we build on systematic bias, is going to move forward. But there's a lot of the concept now is in terms of algorithm vigilance, right? Which is a made-up word based on pharmacoalgorithms. But really, the idea here is really to keep assessing the same algorithm over and over to different populations, right? You have to imagine that care changes, right, with time, right? And if we create an algorithm that was created 2010 to 2015, we apply to the population in 2018. When we get to 2020, that algorithm doesn't work anymore, right? Because things change, the population change, the care change, the disease change, the processes change, everything changed, right? How can we keep that movement, right? How can we keep that going in terms of implementation and validation of that algorithm, right? The population is different as well. And if we take like the example of the healthcare utilization, if we take and create algorithms in a place where healthcare utilization already biased a certain population, it's going to continue to bias that population, right? It's even going to bias even more that population. So really paying attention to some of those details is quite important. It's sometimes more important than the technology per se, which is out there, right? The models are out there. Is really how do we pay attention to that, population, workflow, need, especially the need, right? And how we bring some of that on board to really create things that can actually be helpful. And the other component that I keep saying is like, how do we actually get the population, the patients per se, to bring some of that information and to be included in that algorithm, right? Because if we are not really engaging the community, we are not learning from the community, right? It doesn't really help much, right? Because we are not learning from their needs, from what happens to them at their homes, from what they need. And that's going to always try bias in some ways what we are going to create or implement.
Sorry, thank you so much. We do have a question in the chat. And before I get to that, just a quick follow-up in terms of data collection, because I think, one of the big things that both of you emphasized was the need to make sure that you have some level of quality control over the data and managing that aspect. It kind of reminds me of information theory in the sense that you're really focusing on how data is encoded and decoded, right? And from that perspective, I think about, for example, my mother who's more than 70 years old and how I might, how you might collect information from her, for her electronic health record versus my niece, who will immediately, get on her mobile device and update the information that she needs to. And how do you manage that in this process to make sure that we actually have good data to use?
That's a perfect nightmare question. Thank you for that. Yeah, it's a hard one to answer, but I think you're totally correct. People are different, right? And there's this enormous gap, right? The kids, they can take a mobile device and click and they can tell us everything, right? How do we actually take some of that? I think in some ways we could try to use technology where people can speak or can, have, somebody who helps them to some of that. But it's difficult. I think it's very difficult. There are ways now of people recording visits and recording conversations and trying to use speech recognition and natural language process to solve some of this. I think we are not quite there yet for some of those. We are using it, but I think we are still testing and trying to promote this, right? But really having people to pay more attention to some of that population that requires a little bit more is important. And I don't have a final answer for this. Maybe Jareen does, but
Nope.
I think we could try to use some of that technology. I think that's the use of the technology, right? Trying to bring some of the technology to use to where we want it to be, where we need it to be used, basically.
Mhm.
Okay, great. Thank you very much. Let me get to the question in the channel. And so the first comment was, thanks for this excellent presentation. How does the need for training apply to researchers trying to address health disparities in training researchers? And then a follow-up question is, more specifically, some considerations, suggestions were provided for training healthcare workers. And they're looking for considerations for future training for researchers, pre and postdoctoral training, and AI applications for research.
No, it's a great question. So the first question around researchers trying to address health disparities, I think that if we are going to be, any of us who is embarking in a field that in fact will intersect with anything related to health equity, health inequities, health disparities, anything that may in fact play a role in that space has an obligation to, at some level, become, I don't know if the word is trained, but more than self-aware of the fact that these exist, like that biases and racism and classism, et cetera, exist, because they impact the research that we do. And so whether that means we include more diverse members on our teams, whether that means that we are tapping into more individuals with lived experiences to help us figure out where our blind spots are, whether that means we take actual courses to better understand the interplay of those social determinants of health on what we're doing, all of that I think is very relevant to the training that is happening. And this is like any research that deals with human beings, really needs that kind of foundational knowledge, not just AI. And then there's pre and postdoctoral. You may want to add to that as well, Eneida.
Yeah, no, I agree with everything you said, Jareen. I think the training is at all levels, actually. I think we need to, we have AI every day in our lives. We search Google is AI, right? We answer a phone, we are calling Delta Airlines, United Airlines is AI in the back, right? Anything we do is AI, and people are so familiar with that they don't really understand the other aspects. But when we are dealing with patients and we are dealing with people in general, then it's not necessarily just patients, but people in general, there are risks in that we need to really pay attention to it. So I'm in favor of adding some of this in the context of medical schools, undergraduate programs, pre and postdoctoral degrees. Of course, we don't need everybody to know what deep learning is, right? We don't need everybody to know what, neural networks or random forests are, but we need people to understand that when they are using AI, right, that was based on something that they have to interpret this way or that way. Understanding it's like understanding interpretability of laboratory tests, right? People sort of understand because they were training and understanding that. We don't train folks for risk assessments, an algorithm that was created for X, Y, or Z, right? And I think that's the kind of training that I'm thinking, training on the bias, training on the on the different ways you're going to apply that. And if you're applying it the wrong way, you may harm particular populations, right? So I think that's the kind of training that I was talking about, really basic understanding of that concept of using data for the rest.
And Dr. West, I agree with you totally. I think that racism in healthcare should be added to curriculum at all levels.
Yeah, let me just share the link to the AI population.
And while you're sharing the link, I just want to take the opportunity to thank you both again for such a great presentation and great information and a great discussion. We are at 1 o'clock on the dot, and so thank you all who were able to join and participate. I believe that this will be available. It's a recorded session, so it'll be available for folks who did not get a chance, and you'll be able to share it with them as well.
Yeah, and I just, thank you, Josette. I just added the link there for folks if they want to click.
Thank you. Thank you both.
Thank you. Bye.
Here. Bye-bye.
Thank you.